All right, guys, I need to get started. I want to make sure that I cover the stuff that you'll be tested upon. So there are a few things that I'm going to skip over, and I'll let you know as to what I'm skipping over, number one. And like I said, I'm going to see you again on Monday for a few minutes, and we'll go through more stuff so that you don't have to cover as much on your own. Okay. All right. Now, with vitamin D. Vitamin D, when you think about vitamin D, you think of calcium. When you think about vitamin D, you also think about how there might be lack of sun exposure, hence this particular slide. Okay. Northern hemisphere, whatnot. Now with this, here's the words. However, pictures speak 1,000 words. And let me take you through this. There are two types of vitamin D. First, what you will absorb or what exists in the skin, 7-dehydrocholesterol, and then what you will take in the diet. What is in the skin is a D3. What is in the diet is a D2. Are you guys with me? Once again, from the diet, it's vitamin D2, and what it is in your skin is vitamin D3. So if it's going to be a fat-soluble vitamin, the type of absorption that we went through earlier was through the chylomicron process, and that'll be through the diet. However, if it's from the skin, it is the UV ultraviolet B rays that will activate 7-dehydrocholesterol. Then we come to a common denominator, vitamin D. This will enter circulation, travel to the liver, where you have an enzyme, 25-hydroxylase. This is review. This stuff you should have seen and have understood. And now at this point, if you haven't, then here it is, and you will have it permanently etched in your hearts and minds. 25-hydroxylase travels to the liver. 25-hydroxylase will work on the vitamin D that is either from the diet or from the skin. This is the major circulating metabolite. What is? The 25-hydroxyvitamin D. That's a major circulating metabolite, but is this the form that is the active form? Is this the form that will reabsorb your calcium? No, not quite yet. Now, before I go on to the next step, something that I need you to understand. So, the function of vitamin D in its active form is reabsorption of both calcium and phosphate. From where? From the intestine. From the intestine. All right, so if it's going to reabsorb calcium, what you need to keep in mind is there has to be a triggering aspect. And that triggering aspect is the low calcium. All right, I branched off a little bit because I need you to understand this. If it's the low calcium that you need to reabsorb the calcium in the first place, it is going to stimulate what particular hormone? PTH, parathyroid hormone. All right. So with that in mind, let's bring this stuff together. 25-hydroxy vitamin D, major metabolite. Low calcium has triggered the release of parathyroid from your parathyroid hormone from your parathyroids. It will stimulate 1-hydroxylase. 1-hydroxylase will act upon 25-hydroxy vitamin D to synthesize. I should not have highlighted this because this is something that we'll see later on your right side with the bone. So let's focus upon the kidneys. Let's focus upon the intestines right now. So now the active metabolite is 1,25-dihydroxy vitamin D. So why did we need this in the first place? What were our calcium levels like? Were they high or were they low? They were low to begin with. If they were low to begin with, then who got released? Who was signaled to come out and play? PTH, parathyroid hormone. Parathyroid hormone came in, activated 1-hydroxylase, produced your 1,25-dihydroxycholecalciferol, or calcitriol, or calcitrol, all one and the same. And then where did this travel? This traveled to the intestine to reabsorb both your calcium and phosphate. And that's what we're seeing here. Please don't forget about the phosphate. Because what's so important about the phosphate? You have calcium. You hear that all of the time. But you need the phosphate as well so that you can have mineralization. Do you guys hear me? Mineralization for both calcium and phosphate. And then we'll hit upon the bone in a little bit, because that's something that you'll see with bone mechanism, soft tissue tumors, and stuff like that. So we'll hit that in a little bit, but right now I need you to understand the left arm of that graph. Oh, I'm sorry, the right arm of the graph. Right arm. I was never really good at that. All right. So now regulation of 125 dihydroxy vitamin D produced where? Well, it was the 1-alpha hydroxylase from the kidneys. Who stimulated it? Parathyroid hormone. Why? Low calcium. Always ask yourself why. Don't just settle for an answer. Just like anything else in life, don't settle. Ask why so that you're completely content and satisfied. All right. So now, hypocalcemia, release PTH, stimulates alpha-1 hydroxylase. What does that do? Converts it. This is all in words. We've gone through this already. 1-alpha hydroxylase, right? What's the major metabolite that's circulating? The 25. Where's all that coming from? From two sources. One from the diet. What form is that? D2 or D3? D2. From the skin, it's D3. Who activated the one from the skin? UVB. Yes. Excellent. Feedback loop. Increased levels of, just like anything else, endocrine physio, just like anything else, a feedback loop. 125 dihydroxy vitamin D. What would inhibit? If it's a feedback loop, what enzyme is it going to inhibit? It's alpha-1 hydroxylase. There it is. The feedback loop. If you have enough of that 125, you don't need to produce anymore. You want to inhibit, correct? The enzyme. And the opposite's true if you have decreased levels of 125. I'm sorry, that arrow should be directed more accurately to the 1-alpha hydroxylase. All right, now vitamin D functioning. It is a fat-soluble vitamin. If it's a fat-soluble vitamin, what do you think it's going to act? DNA? Yes. So it acts like a steroid. Remember steroids? Steroids, they're fat-soluble, meaning they can penetrate through the phospholipid membrane and travel down to a nucleus, and there's a DNA. And then it is going to induce transcription. If you induce transcription, who are you going to produce? Remember that stuff? mRNA? mRNA? Transcription. Calcium in essence, and this is the proposed mechanism. The proposed mechanism for reabsorption of both calcium and phosphate from where? From small intestine. But how is that taking place? Well, the theory that's out there, because it is a lipid-soluble vitamin and that it can go into the cell and into the DNA, that it will actually induce the induction of calcium-binding proteins. Are you guys with me? Okay. So that's for reabsorption of both calcium and phosphorus, homeostasis. Now here, I just want to touch upon this briefly so that you are at least aware as to what's going on. At high doses, okay, they don't know everything there is to know. They're still finding out as to what's taking place with these vitamins, interesting enough. At high doses, remember here on your on the other side was your was the kidney, or I'm sorry, the small intestine. So here on high doses, what ends up happening, here's the active form, 125 dihydroxy. It acts upon osteoblasts. What are osteoblasts? Do they build bones or do they break it down? They build bones. B for building bones. All right. And then what it does is, because it is a fat-soluble vitamin, it travels into the cell, and what did I say? It will work upon your DNA. In this particular case, it will induce a particular ligand, and that is known as receptor activator of nuclear factor kappa B ligand, I'm sorry. So once again, receptor activator of nuclear factor kappa B ligand. What's a ligand? Ligand is basically a substance that will bind to a receptor, always. Ligand, general concepts in medicine, just makes it that much easier for you. You don't have to memorize ligand. What you do have to memorize is the rank. And if it's a ligand that it's inducing, who's inducing it? The 1,25-dihydroxyvitamin D. And this in turn will actually activate osteoclasts. And because of this, what do osteoclasts do? Resorption of bone. Don't get those two mixed up. What's reabsorption? Reabsorption means that you're taking it back out. Resorption means that you're taking it out for the first time. If you're reabsorbing something from the bone, what are you doing? You're taking the calcium and the phosphorus out of the bone for the first time. This is high doses. I need you to understand this because you're going to see this next semester. Now, as far as mineralization, what do we say about this? For mineralization, what do you need? Number 1, calcium. Number 2, phosphorus. So you need both of those. And where's that coming from in terms of vitamin D? From the small intestine. So, stimulates osteoblasts, and I was explaining to you earlier as to how it's going about reabsorbing the calcium. And it is the osteocalcin that it induces so that it can reabsorb the calcium. And this is where I like you to focus, is the small intestine, this particular mechanism. All right. By this, I mean by the small intestine. All right. Now, let's go into vitamin D deficiency. If it's vitamin D deficiency, what do you think you're going to suffer from? Increased levels of calcium or decreased levels? Decreased levels of both calcium and phosphorus. So as we go through this, we'll talk about the deficiency, obviously, number 1. Next, we'll talk about the mineralization. Please don't forget, if it's mineralization, you need both calcium and phosphorus. And then we'll go through the spectrum of pathologies, which include rickets. Rickets is vitamin D deficiency in what? In whom? In children. If it's in adults, it's osteomalacia. Further down the line, once again, I don't need you to memorize this. I need you to understand this. As the disease progressively gets, if the deficiency is progressively worse, it goes on to renal osteodystrophy, or renal osteodystrophy may result in osteoitis, fibrosis cystica, but you don't see this as much anymore, but likes to be tested. All right, now let's go through the vitamin D deficiency. You don't have the vitamin D. You have hypocalcemia. Who's being triggered? Parathyroid hormone. If it's parathyroid hormone, it's going to travel to the kidneys and stimulate what enzyme? 1-alpha hydroxylase. If it's 1-alpha hydroxylase, is there any vitamin D to activate? No, there isn't. It's vitamin D deficiency. So think about what you're doing. All right, so now at this point, you do have increased levels of PTH. Why? Because you're hypocalcemic. But what about your activated, what about 1,25-dihydroxycholecalciferol? It's decreased. It's decreased. Now, if you have increased, let's go through this. 1-alpha 1 hydroxylase unable to convert 25, which is the major circulating metabolite, into 125. And then you have decreased renal reabsorption of calcium and increased renal excretion. This is important. Increased renal excretion of phosphorus. Why? Because of increased PTH. Why do you have increased PTH? Because you have low levels of calcium. Always ask why, and it'll make sense to you. So decreased levels of calcium, increased levels of PTH. Case scenario, you're going to have a patient with what type of urine? Hyperphosphaturic or hypophosphaturic? What type of phosphorus, or what type of urine are you going to have? You're going to have increased amounts of phosphate in your urine. Why? Because you have increased levels of PTH. Why? Because you have low levels of calcium. So your urine will be hyperphosphaturic because the PTH is excreting all of that phosphate. Are you guys with me? Phosphaturic. What about the blood? What about the phosphate there? It's low. It's hypo. So think about and look at the word and what it's describing. If it's the urine, if it's urine and it's vitamin E deficiency, it's going to be hyperphosphaturic. If it's the blood, it's going to be hypophosphatemic blood.